Welcome back to the deep dive, everybody. We're diving back into the ever-changing world of 340B.
Always something new, right?
Seems like it. And I think you, our listeners, are probably right there with us, trying to keep up with everything going on.
Yeah, so many moving pieces.
Exactly. So that's what we're aiming to do today, give you the need to know on what's been happening.
That's right. We've been digging into some recent news articles and even a podcast to try and get a handle on all this.
A 340B health podcast, to be
All
exact.
right.
And I have to say, it's wild to see how dynamic the 340B landscape is right now. We've got legal battles playing out, manufacturers trying to push the boundaries, new technologies entering the mix, and even some big changes happening within HRSA.
Definitely a lot to unpack.
No kidding. But that's why we're here, to break it down and make sense of it all.
Absolutely. And a big thank you to Aventi Health for sponsoring this deep dive. Their dedication to putting customers first in 340B third-party administration is something we really appreciate.
All right, let's get started. First up, we're going to Arkansas, where things are heating up over contract pharmacies.
Oh, yeah. Arkansas has been on the front lines when it comes to pushing back against manufacturer restrictions on contract pharmacies.
And it seems like they just scored a major win, right?
They did. AstraZeneca, the last big manufacturer holding out, has finally agreed to comply with Arkansas's Act 1103. That's their first in the nation contract pharmacy access law.
So what exactly happened? Can you give us the rundown?
Sure. On April 3rd, AstraZeneca announced that they'd be lifting those restrictions for Arkansas 340B providers. This was retroactive to April 1st. But this wasn't out of the goodness of their hearts. It was because of an order from the state.
So they were compelled to comply.
Yep. Just 2 days before AstraZeneca's announcement, the Arkansas Insurance Department Commissioner, Alan McLean, issued an order saying they were breaking the law, Act 1103, and had to allow 340B drug access at all contract pharmacy delivery locations.
Wow, so Arkansas basically put its foot down and said enough is enough.
Exactly. And that's a big deal because it shows that states can take action to enforce their laws and protect covered entities.
I bet other states are watching this closely, thinking about doing something similar.
Oh, absolutely. Since Arkansas passed Act 1103 back in May of 2021, 9 other states have enacted similar laws. But Arkansas is the only one that's really gone after a manufacturer like this.
So AstraZeneca lifted the restrictions, case closed, right?
Not so fast. Here's where it gets even more interesting. AstraZeneca is actually still fighting Act 1103 in federal court.
So they're complying but also suing.
Yep. Their lawsuit goes back to March 2024, and the trial is set for September 23rd.
So they're doing what they have to do for now, but still trying to get the law overturned. It sounds like they're trying to have their cake and eat it too.
Well, that's one way to put it. AstraZeneca says they disagree with the state order, but that they're still committed to the 340B program. Their argument is that their old policy, which let covered entities use either their own on-site pharmacy or one designated contract pharmacy, already met the requirements of the law.
So they felt their existing setup was good enough.
Right. But the state of Arkansas disagreed, obviously. And this isn't the first time Act 1103 has been challenged in court. The drug industry as a whole tried to get it thrown out, but the U.S. Eighth Circuit Court of Appeals upheld it. The Supreme Court even declined to hear the case. After that ruling, AstraZeneca was the only major manufacturer still sticking to its restrictions.
So it seems like Arkansas has really drawn a line in the sand here.
Yeah, it's definitely a story worth watching closely.
For sure. All right, shifting gears a bit, let's talk about something that's been brewing for a while now.
Yeah.
The whole issue of drug manufacturer rebate models and HRSA's stance on them.
Yeah, this has been a hot topic. And HRSA has been really clear that they're not on board with these models. It's all about protecting how covered entities access those discounted medications.
HRSA's even gone to court over this, right?
They have. Back on March 17th, they filed a brief defending their decision to block drug companies from using these rebate models.
So what's HRSA's reasoning here?
Basically, they're saying, hey, we have the authority to oversee how this program works, and these rebate models are trying to change the rules of the game. They argue that these models would completely upend how the 340B program has operated for the past 30 years. They're calling their decision not arbitrary and capricious, meaning they had good reason to do it.
So they're standing their ground, saying these rebate models are a step too far.
That's right. And it's not just HRSA who feels this way. The American Hospital Association, the AHA, and a bunch of other groups like the Children's Hospital Association, the Association of American Medical Colleges, and America's Essential Hospitals have all filed briefs supporting HRSA.
So the hospitals are backing up her saw on this. What are their concerns?
The AHA is arguing that the law doesn't give manufacturers the right to withhold discounts just because they want purchase data or to do prepayment audits. They're saying her saw was right to reject these rebate policies because they go against the whole point of the program, which is to give upfront discounts to covered entities. Hospitals are worried about extra paperwork and patients having trouble getting their meds.
So it sounds like a power struggle is going on.
Yeah, there's definitely tension between the manufacturers wanting more control and the hospitals wanting to protect the benefits of the program. And it's not just limited to a few companies either. The AHA and other groups have also filed briefs in cases involving Sanofi, Calderos, and Johnson & Johnson, all of whom are trying to push through these rebate models.
It seems like these legal battles, both over contract pharmacies and rebates, really highlight how much disagreement there is about the rules and goals of the 340B program.
It does. And it's a reminder that covered entities have to stay informed and be active if they want to protect themselves and their patients.
Absolutely. Now let's talk about something a little different. The role of technology in 340B. You mentioned a 340B Health podcast about AI and automation, right?
Yeah, I found it really insightful. They interviewed Kristen Chupka, who's the system director of the 340B program for Dartmouth Health. She talked about the practical side of using these technologies in 340B.
She made an important distinction between automation and AI, didn't she?
She did. She said automation is basically about following set rules, like programming a system to do a repetitive task. AI, on the other hand, is about machines making decisions and predictions and actually learning as they go. It's the difference between we can do this and should we do this.
So automation is about making things more efficient, while AI is more about letting computers analyze and even solve problems on their own. What kind of applications did she talk about for pharmacies in general?
She mentioned specialty authorizations, which can be a huge headache. Imagine AI filling out those forms and submitting them automatically, pulling info from electronic medical records and interacting with the payer systems. That would free up so much time for pharmacy staff to focus on patients.
That would be a game changer for a lot of pharmacies. What about 340B specifically? Where does she see automation and AI fitting in there?
That's where things get interesting. She was pretty cautious about using AI for auditing 340B claims. She worried that if the AI learned the wrong things, it could lead to inaccurate compliance assessments. She also brought up the challenges of getting AI to work with all the different electronic medical record systems out there and the importance of keeping patient information secure.
Yeah, you wouldn't want to put your compliance in the hands of a computer that might make mistakes. But what about automation? Was she more positive about that?
Much more. She was all for using automation for things like checking provider and location eligibility and doing those orphan drug checks.
Quick reminder, orphan drug checks are about making sure drugs with orphan drug designation aren't being used in certain 340B situations.
Right. And with those kinds of tasks, the rules are pretty clear-cut, so automation can easily identify compliant claims. Dartmouth Health is already using automation to audit all of their claims across 9 covered entities. They went from auditing about 10% manually to 100% with automation.
Wow, auditing every single claim. That must make a huge difference in terms of compliance.
It does. For their disproportionate share hospital alone, they went from having to manually audit thousands of claims down to about 2,000 per month. But they don't just blindly trust the automation. They do something called audit the auditor, where they double-check a sample of the claims the system says are compliant, just to make sure it's working right.
That's smart. You always need a human in the loop to make sure the machines are doing their job properly.
Exactly. And Kristen also emphasized that someone still needs to keep the system up to date, adding new providers, updating Medicaid plan information, and all that. Interestingly, she said that automation hasn't reduced their staff, but it has allowed them to do that 100% auditing and really improve their compliance.
So they're getting more done with the same resources. That's impressive. Did you talk about any other potential uses for AI in the future of 340B?
She mentioned some possibilities, like using it for financial modeling, predicting capture rates, and even helping with NDC file and package size checks. But she thinks those are areas that need more exploration.
Of course, we can't talk about AI without considering the ethical and legal side of things, especially in healthcare. What did Kristen have to say about that?
She brought up some big questions, like should patients know if AI is being used in their care? And what about the relationship between patients and their doctors? Could AI disrupt that? She also talked about legal stuff, like state regulations for pharmacies, data security, and who's liable if the AI makes a mistake.
Yeah, those are all really important things to consider. It sounds like there are a lot of different opinions in the 340B community about AI.
There are. She said some people in her workshop were totally against it, some were cautiously optimistic, and some were eager to explore it further. It's definitely a conversation that's just getting started.
Now, before we wrap up, we have to talk about some big news coming out of her SAW itself, or rather, HHS. Seems they're going through some major changes.
Yeah, this is big. Late March saw a huge restructuring announcement, including a plan to cut 20,000 jobs. And get this, her SAW is being merged with four other programs into a new entity called the Administration for a Healthy America, or AHA.
Wow, that's a lot to take in. Which other agencies are being folded into this new AHA?
The Substance Abuse and Mental Health Services Administration, SAMHSA, the Agency for Toxic Substances and Disease Registry, ATSDR, the National Institute for Occupational Safety and Health, and the Office of the Assistant Secretary for Health, OASH. But of all of them, HRSA is the biggest.
And what's the reason behind this shakeup?
It's part of President Trump's new Department of Government Efficiency, or DOGE. Elon Musk is leading the charge. The official line is that they want to streamline things and improve coordination of health resources for low-income Americans. They're focusing on primary care, maternal and child health, mental health, environmental health, HIV/AIDS, and workforce development. The name Administration for a Healthy America is even a nod to HHS Secretary Robert F. Kennedy Jr.'s campaign promise to make America healthy again.
So a major reorganization, a new name, and a new focus. What does all this mean for her SAW and the 340B program?
That's the million-dollar question, and right now, no one really knows for sure. HHS hasn't said if HRSA will lose staff in these cuts.
All
And
right.
the longtime spokesperson for HRSA just retired, so there's a lot of uncertainty. Secretary Kennedy hasn't spoken publicly about 340B yet, but HHS has continued to fight those drug maker rebate models under his leadership.
So there's some continuity there at least. How have people been reacting to this HHS restructuring?
As you might expect, it depends on who you ask. Republicans in Congress are mostly supportive. They say HHS needs streamlining. Democrats, on the other hand, are worried about the impact on healthcare workers, HIV/AIDS programs, community health centers, and a bunch of other areas. They're also criticizing the lack of transparency around these changes.
What about from the healthcare organizations themselves?
Well, the National Association of Community Health Centers, or NACHC, says they're ready to work with the new administration to support primary care and make sure community health centers have the resources they need. America's Essential Hospitals is concerned about whether the changes will affect their ability to serve low-income and older patients. And the American Public Health Association, or APHA, called the whole thing thoughtless and basically a way to devastate the workforce, which they say will hurt public health.
So there's a lot of anxiety about what this means for the future.
Definitely. It's something covered entities need to keep a close eye on.
Absolutely. So as we wrap up today's deep dive, it's clear that the 340B world is in constant flux. We've seen wins for covered entities in Arkansas, ongoing battles over those rebate models, the exciting potential but also the challenges of new technologies like AI, and now a major reshuffling within HHS.
And it's all connected. Those legal challenges affect how manufacturers deal with the program. The fight against rebate models is about protecting the heart of 340B discounts for covered entities. Technology brings both opportunities and new things to worry about. And the changes at HHS could completely reshape how the program is run.
And through it all, having partners like Aventi Health, who prioritize their customers in 340B third-party administration, can make a huge difference for covered entities.
Couldn't agree more.
So here's something for all of you listening to think about. With all these changes happening, states taking action, push back against those rebate schemes, the promise and the caution around AI and this big HHS restructuring, what big changes do you see coming to 340B in the next few years? And how can covered entities prepare themselves and continue to serve their patients effectively? It's a lot to consider, but hopefully this deep dive has given you some helpful insights. Thanks for joining us.